guys for coming back again. Again, my name's Marie. I am the ambulatory care pharmacy specialist. I work in our primary care clinic, so I do a lot of help with diabetes, and that's what we're talking about today, specifically the newer classes of medications. So briefly though, I do want to kind of review some of the high points of things we touched on last week because it was a ton of information, so I thank you guys for sticking with me last week. So briefly, we talked about the old medications, right? So we talked about sulfonylureas and how there might be this increased cardiovascular risk, but it's mostly from systematic reviews, meta-analyses, and the guidelines are split. ADA says that maybe they're neutral, but then the endocrinology guideline says there might be a risk. So we're not quite sure, but we definitely don't see a benefit with the sulfonylureas. Our TZDs, they are contraindicated in heart failure. We all know that. We went over a case where someone had heart failure and was on Actos or pioglitazone, so we stopped it. And rosiglitazone used to have this black box warning for this increased risk of MI that had been seen in a meta-analysis, but that has since been removed, so you can use rosiglitazone. There's no black box warning. I will tell you again that we're not really using much rosiglitazone in practice. If we're going to use a TZD, we use pioglitazone mostly as our insulin sensitizer. And the good thing about pioglitazone is while it's still contraindicated in heart failure, so that does not change, we still see the risk. There may be this beneficial effect in cardiovascular outcomes. So we saw one of the secondary outcomes, some benefit in cardiovascular endpoints. Our major adverse cardiovascular events was a secondary outcome in one trial, looked to be beneficial. The IRIS study was our non-diabetics, but they did have insulin resistance and had had a previous TIA or stroke, and we saw some benefit with pioglitazone. So there might be a niche for this medication. But then the other ones we talked about were our newer medicines, so our DPP-4 inhibitors, and we just highlighted that all of them, so we have the four, so sitagliptin, saxagliptin, linagliptin, and alogliptin. 2 out of the 4 have, all of them have neutral effects when it comes to major adverse cardiovascular events. So remember, FDA says you have to show non-inferiority to placebo. They all did that, so that's good. 2 of them showed some concerns when it comes to heart failure. So whether it be just heart failure in general, increased risk of heart failure, or hospitalizations for heart failure, and that was saxagliptin and alogliptin. So both of those carry a warning for that risk. Then we talked about metformin and this potential legacy effect because we had the UK-PDS study. And when I looked back, so the UK-PDS study followed patients on metformin for about 10 years. So that was one of the questions that came up last time. And so they were on it about 10 years and they saw lower risk of MI in patients on metformin. Again, this was a small sample of that study though. They were overweight patients, maybe 400 or so patients in this group, but it looked better than conventional therapy, which was diet and lower risk of MI. 10 years later, they look back at these people that had been on metformin in that previous study. They could be on anything at this point, and they were still seeing lower rates of MI in the patients that had once been on metformin. So they call it this legacy effect. Maybe there's something there. And then we spent a lot of time talking about our SGLT2 inhibitors. We have 4 of them, but we talked specifically about trials for 3 of them. The first one that we talked about was empagliflozin or Jardiance, and so that was kind of our blockbuster study that first came out and showed lower rates of major adverse cardiovascular events. And then it was also the primary composite was driven by death from cardiovascular causes, which was really exciting. And so it actually led to this FDA indication. So in patients with cardiovascular disease, and diabetes, this medication could reduce the risk of future cardiovascular events. We talked about Invokana or canagliflozin. It had its version of these studies they have to go through. Also saw decreased primary outcome, but none of the pieces of the composite themselves were statistically significant. So no real driver of that endpoint. We still saw for both of them decreased heart failure hospitalizations. We did see an increased risk of amputations, which was very concerning and led to a black box warning. And then potentially some renal benefits with canagliflozin that'll then be talked about in our credence study that'll come out. And then the newest one, the DECLARE-TIMI study with dapagliflozin or Farxiga, was recently published, and this one did not see a significant difference in the primary endpoint of MACE, so it was non-inferior to placebo, again, what we're supposed to show, but we still saw lower heart failure hospitalizations and still saw this potential renal benefit. that was a gist of everything we kind of talked about last time. Any specific questions about that? We can always circle back. Okay. So then the other class of medications that we wanted to talk about today are GLP-1 receptor agonists. And these medications mimic our body's endogenous incretin hormone GLP-1, resulting in a glucose-dependent insulin secretion. So what's nice about these is, again, it's glucose-dependent, so we don't run that same risk of hypoglycemia that we've seen with sulfonylureas that also increase insulin secretion. And there's also evidence that the receptor for GLP-1 is expressed in vascular endothelium, smooth muscle cells, and cardiomyocytes. We've seen some experimental studies that these medications may improve insulin sensitivity, left ventricular remodeling, and cardiac contractility. And we see favorable effect on cardiovascular risk factors in general. So we see weight loss more so with these agents than we do with the SGLT2 inhibitors. Some decrease in blood pressure, very mild changes in blood pressure, improved endothelial function, and a slight decrease in LDL. But again, nowhere on the magnitude of what we see with some of our lipid-lowering therapies. Right now, we have 5 on the market. One of them we will talk about in a few minutes. GSK is no longer making it. And it's probably because there are so many on the market at this point. So we have our initial ones, which were first dosed twice a day. So these medications are injectables. They're non-insulin injectables, but that has been thought of as a barrier to get patients to take them. But I will say in practice, I feel like if you're able to talk with them, show them the needle, and then we are fortunate in some of our offices where we have samples, and so we can even do the first injection with the patient and go through that with them. And I feel like they're very well tolerated, small needles, very similar to what you see for your insulin administration. They can be dosed, generally we do either once a day or weekly. We don't really do the twice a day option anymore for obvious reasons. And again, we talked about how they work. They can also help with some increased insulin sensitivity, decreased glucagon secretion. But some of the other benefits that they have compared to those DPP-4 inhibitors that we talked about last week, which also have that same increased insulin secretion in response to glucose, is they also have increased satiety. So this hormone works on our body's satiety effect, so we feel fuller sooner. And it also delays gastric emptying, so we feel fuller longer. We find that this helps promote weight loss in the patients, and they find that they're eating smaller portions of food. It's helpful to counsel them on that, but I think ultimately too, they do find whether or not they've been extensively counseled on it, they will come back and say, oh, I just can't eat as much as I want to, or I start having like really bad kind of discomfort in my stomach. So we try to talk with them ahead of time. That also leads to the nausea, vomiting that we can see with this class of medication, so counseling them on that. There's a slight increase in heart rate that we can see. There's no contraindication in patients with any sort of arrhythmia that has been documented, but we do keep that in mind if we have someone with really poorly controlled atrial fibrillation, like we can't get them brake control, perhaps we wait to consider one of these. And then this questionable risk of acute pancreatitis, same kind of idea that we talked about with our DPP-4 inhibitors. We don't use it in people with a history of pancreatitis unless we know for sure what caused it, and that's not going to happen again. And then we worry about this medullary thyroid carcinoma. So they saw this in rats, and it is a black box warning on all of these medications. Speaking to endocrinologists, we've had a handful of real life scenarios where we believe these medications may have contributed to this, but generally we're counseling people on monitoring for difficulty swallowing, lumps in their throat, trouble speaking, and that they get evaluated by their physician if they have any concerns for that, and we definitely rule out any family history of this type of carcinoma. You can see that some of them are renally adjusted, but the good thing is most of them aren't. So for diabetes, that's really helpful because a lot of our medications get eliminated right away in our CKD patients.
Is the nausea because they're eating too much or independent of food?
I found that it's independent of food. I think they can manage it a little bit better if they start small and see how they do. Some of the ways we get around it is we'll say having some food on your stomach when you take it, just like any medication. Or taking it closer to bedtime, because some patients have felt like if they sleep through the first couple hours, they feel fine. In the once weekly options, I have had people say the whole next day they feel a little more nauseated. but it usually passes, and there's so many benefits that they see from these medications, in particular the weight loss, that most people are able to get through it. And we do titrate the dose. So most of them, you start at the lower dose, and then you'll increase, like for example, liraglutide, Victoza, one of our most common. You do a small dose for a week that isn't really studied to have blood glucose effects to a great extent, but it's just that tolerability dose, and then we go to the 1.2. If we still need more blood sugar control, then we'll go to 1.8. So we try to be careful about titrating those. Okay, so there's a question on how are these medications actually helping. So last week when we talked about the SGLT2 inhibitors, we talked about how we believe it's more to do with the hemodynamic effect. So we're seeing this diuresis, lower blood pressure, decreased weight, maybe this different fuel source where we talked about using ketones versus our normal fuel source. A lot of these things are still in animal models. We're still trying to figure them out, but we're trying as best we can to explain these benefits that we're seeing. When it comes to the GLP-1 receptor agonist, we believe it's more to do with anti-atherogenic effects. And that comes to light when we look at the data. So when we look at SGLT2 inhibitors, remember we were surprised, especially in infrared, that we saw the benefits in cardiovascular death in the composite within like 3 to 6 months of therapy. And so that's another thing that made us think maybe this is more hemodynamic. When we look at the GLP-1 studies, we're talking more like a 12-month onset of the real benefit seen, more like some of our atherogenic or anti-atherogenic studies where we look at like statins and lipid-lowering therapies. So as we've said before, since 2008, all new medications are going to have to show that they are non-inferior in cardiovascular outcomes when compared to placebo. So these are two of the studies that we'll go through real quick because they didn't really find much to write home about. So we have lixisenatide versus placebo, and they had a recent acute coronary syndrome, and it was non-inferior to placebo. So again, safe, but no real benefit seen, and these were earlier studies. Then we had the Excel study, exenatide versus placebo, so our first GLP-1 to market versus placebo in type 2 diabetes with majority of patients with cardiovascular disease, and again, non-inferior to placebo. Both of these have shorter half-lives, so when we looked at the medications, these are ones that are dosed either once a day or twice a day. And they're also less homologous to our endogenous GLP-1, so about 53% similar to what we have in our bodies, which is one of the reasons they think maybe we didn't see a benefit with these. It also always has to do with the study design, so always keep that in mind. When we talk about liraglutide, it's very similar to what we have in our bodies. So 97% homologous to our GLP-1. They modify endogenous GLP-1 to make it stable against degradation by DPP-4, and it extends the half-life. So we get higher levels of these GLP-1 hormone in our body from these medications. And again, this one is special because like we talked about with empagliflozin or Jardiance, this one also has that special FDA indication for risk reduction of major cardiovascular events in patients with diabetes and who have established cardiovascular disease. This class of medications, notably I didn't mention when we looked at just the table of them, they can lower A1C by up to 1.5 percentage points. So when we go through all this data, we talk about SGLT2s, we talk about GLP-1 receptor agonists, but when thinking from a diabetes management standpoint, these are stronger blood sugar lowering medicines than our SGLT2 inhibitors at the end of the day. And then they have more weight loss too. So that is something that we definitely take into account when managing their diabetes. Not to say that's always right, but we do. And like most of these we've gone through, it is quite expensive, so making sure it's covered, but it's very well covered on most people's plans at this point. So the LEADER study was liraglutide's version of this cardiovascular outcomes trial. They had diabetes, they were at least 50 with cardiovascular disease or 60 with risk factors. And they excluded patients with a recent, like within 14 days, acute coronary syndrome or stroke. And they randomized patients to liraglutide 1.8 or the maximally tolerated dose. So let's say they had significant nausea and could only take 1.2, they would keep them there, versus placebo in over 9,000 patients. They looked at this same composite we've been talking about over and over. And 81% of patients had established cardiovascular disease, so the majority of patients. The mean A1C was 8.7%, so a little bit higher than what we saw in some of those SGLT2 inhibitor trials. And they had had diabetes for almost 13 years on average, which when we compare to the other trials, we're looking closer to 10 years. So very kind of risky patients. Most had cardiovascular disease and had diabetes for quite a while. And then notably 18% with heart failure was reported, because like we said, in the SGLT2 inhibitor studies, some of the earlier ones, they didn't even tell us how many people had heart failure at baseline, which is another limitation of those studies, because we just don't know how to always interpret what they found. But here at least we know that 18% had heart failure. And then we see the outcomes. So this is the exciting study for this class of medications. This is the first one that we saw with this. So the primary composite was statistically significant. And remember, the pieces of that were death from cardiovascular causes, MI, and stroke. And so similar to infrared, we see that death from cardiovascular causes was likely the driver of this endpoint. The number needed to treat for the primary outcome was 53. And for death from any cause, it was 72. So still, not something to laugh at. Good data here. I know the p-value for myocardial infarction looks statistically significant, but based on their stats, it was not considered statistically significant. So just the ones in the boxes there. And they saw that patients with a BMI over 30, those who were greater than or equal to 50 that had heart disease, and with EGFR less than 60, looked to be kind of the subgroups that did the best on this medication. Some of that makes sense, right? So we know we're seeing weight loss with these medications, so maybe our obese patients would get more of a benefit. The average weight loss was 2.3 kilograms in the liraglutide group. Systolic blood pressure decreased by 1.2 millimeters of mercury, so again, very minimal changes in blood pressure, but we do see it. Diastolic decreased by 0.6 millimeters of mercury. And then heart rate was 3 beats per minute higher in the liraglutide group versus placebo. So that's the type of difference we're kind of looking at, but that is pretty consistent with most of our GLPs. More nausea in the GLP-1 group. So what they took away from this study is that we saw lower rates of cardiovascular events and death in patients on liraglutide compared to those on placebo. The onset of benefit was 12 to 18 months into this study. So again, much later than we saw in our SGLT2 inhibitor study. And there was less heterogeneity in the composites of the primary outcome. I don't necessarily agree with that as much. I still think there was a driver of this primary outcome. And they say that the results are maybe due to some hemodynamic changes. So we said baby changes in blood pressure, but we do see significant weight loss. But more likely, this looks more like something to do with modified progression of atherosclerotic disease. So then we have our newest SGLT2 inhibitor, semaglutide or Ozempic. It was approved in December of last year. It's, again, very similar to our own GLP-1. It has a long half-life. So the difference here, it's dosed once a week. And it's actually made by the same company that makes liraglutide. And it is primarily bound to albumin, which helps it have its longer half-life. And again, it's expensive, and it achieves steady state in our body within 4 to 5 days of use. So it's not a quick onset, but it can get there before you need a second dose. Its cardiovascular outcome study was SUSTAIN-6, and this was pretty similar to what we saw with the LEADER study. So they had diabetes with heart or cardiovascular disease, they had heart failure, or they had CKD, or they were 60 with at least one risk factor. 24% of patients had heart failure at baseline in this study, so a larger population. And they were randomized to all different doses of semaglutide. So this one has different varying, more options for dosing. So you start at the 0.25 for a month, because it's once a week, so you do that 4 times. And then if they're tolerating it, you go to 0.5. If they still need more blood glucose lowering, you go to 1. And or placebo. This was a smaller study. And again, looking at the same composite outcome that we've talked about, majority of people had cardiovascular disease, long duration of diabetes, and exactly the same average A1C as the LEADER study. So very similar across the board. When we look at the outcomes for this study, it's exciting because the primary composite was non-inferior, and statistically look superior, but it is notable that they did not pre-specify superiority. They said that testing for superiority for the primary outcome was not pre-specified or adjusted. So we cannot walk away from this and say it was superior. You'll read different reviews like the one that came out in JACC recently, and they say that it was superior. And while the numbers look that way, the FDA did not allow them to say that. So when you read how they report the results here, they say a lower number of events or reduced events, but they don't have that same statistical significance in their conclusions. Here, we don't really see that the death from CV causes is driving it. This time is the first time we've talked about non-fatal stroke, which is interesting because all our other studies have either been talking about MI or cardiovascular death. So this is the first one that saw significance for non-fatal stroke. Other things they looked at was revascularization, and that was significant, and new or worsening nephropathy. So when we talk about this, it's different when we talk about our SGLT2 inhibitors. We're thinking, okay, they work in the kidneys, and thinking about some of the renal protective things maybe we see. With this class of medications, we're not quite sure why we might see a benefit. So like I said, in the leader study, the patients with eGFR less than 60 was one of those groups that did best on the liraglutide. And here, we're seeing this benefit again, perhaps because of substantial blood glucose control. However, at the end of the study, the difference from placebo, because they could adjust any background medicines, was pretty negligible. So again, it's hard to say exactly what's given us this benefit. They saw weight decrease. So in the 0.5 milligram group of semaglutide, 2.9 kilograms. So better than liraglutide, and that's the half dose. 4.3 kilogram decrease in the 1 milligram once a week dose. So out of the class right now, if you were to ask me, this one has the most weight loss. This has not been compared head-to-head to liraglutide. You can imagine that if you are a company that makes both of them, it may not be in your best benefit to compare them right out the gate, but when we look at the numbers, maybe there's a little bit more with semaglutide. We know it's got more than dulaglutide or Trulicity that we'll talk about because it has been compared to that, and that was definitive. Systolic blood pressure, 1.3 millimeters of mercury lower, so again, not much difference. Heart rate, 2 beats per minute higher in this group, and then no real difference in diastolic. Oh, I'm so sorry. Oh, I just read, yeah, the pieces of it. Okay, and then side effects were similar. The only interesting thing from the SUSTAIN-6 trial that was different was there was higher risk of retinopathy in the semaglutide group, and they found that this was in patients with a history of retinopathy or high risk for retinopathy. They think it might be because it's such a powerful blood glucose lowering agent. So we've seen that traditionally in some of our insulin studies too, where if we are correcting blood glucose more quickly, we can see worsening retinopathy. It doesn't always persist, but it is something we've seen. So we still counsel patients on it, but again, that is the one time where we think maybe we wouldn't use this medication. In general, it's very well tolerated, and we use it in most, if it's covered on their plan, because it's once weekly. All right, so non-inferior to placebo for that outcome, and then they said 26% lower risk driven by decrease in stroke. So again, their verbiage is different, and they couldn't say superiority based on this study, but when you read about it and you compare it to other trials, it does look like it had very similar, if not better, outcomes than we saw in the liraglutide study. And this is something that they included in the JACC article recently, where they were comparing some of the different studies that we talked about. So you can see that really LEADER and SUSTAIN-6 are the ones with the benefit for the major adverse cardiovascular events. You see the cardiovascular death for liraglutide. You see stroke for the semaglutide. And then the others, it's hit or miss. All-cause mortality may look better for some, but again, that's not the primary endpoint, so they can't really hang their hat on that at this point. Liraglutide still is the only one with this indication. I imagine that semaglutide will do maybe a bigger study and look into this. I know that in primary care, we have a study going on in patients without diabetes, but with heart disease, enrolling them in a trial taking semaglutide. So a different patient population, because some of the physicians are really believe that there's this benefit outside of just our diabetic patients in terms of cardiovascular disease. And there was more weight loss with semaglutide. Some updates. So show some things that have either come out or are about to. So the Harmony Outcome Study was albiglutide versus placebo. So this is a GSK product that they are no longer producing. But what's interesting is in their study, they actually were superior to placebo for major adverse cardiovascular events. They don't really state, or I wasn't able to exactly find why they stopped producing it. It was a once weekly GLP-1, and so perhaps now that we're getting more and more of those coming to market, they wanted to do less with this medicine and pursue other ones. But that does help our feelings of this class effect, because again, albiglutide is another one that's more similar to our own GLP-1. The Rewind study is going to be presented at ADA in 2019, but they've done their press release from Lilly, and they saw that they had superior outcomes in major adverse cardiovascular events. Their kind of hallmark is that they had very low rates of patients with heart disease. So when we compare this to our other studies, we're talking over 80% of patients with heart disease. They had 31%. So they're saying more of a primary prevention type look on this study compared to the other ones that we've seen. And then the Pioneer 6 study, we're expecting the publication. They said fourth quarter of 2018, so we are quickly ending that. So hopefully this study will come out soon. But it's actually oral semaglutide. So they are producing an oral option to be determined on how the cost plays out for that. But they compared it to placebo, and it was non-inferior for major adverse cardiovascular events. So again, what they had to prove. But then they did see decreased cardiovascular death and all-cause mortality when compared to placebo. So there's excitement there because we could do it in combination. Adherence could be better. Getting more patients on it with an oral option might be preferred, and they would definitely have the market in that scenario because we have no other options. Okay, so we'll do quickly a couple patient cases. So if you remember the guy we saw before, he was a 72-year-old male. He had diabetes, heart failure, hypertension, and atrial fibrillation. He had gained 20 pounds in 2 weeks, and we noted that he was on pioglitazone. So right out the gate, we took that away because he should have never been on it, and we knew it was contraindicated, and it could also be contributing to his weight gain. Well, then he comes back in 4 weeks, and his weight's better. After you made the medication changes, including adjusting his diuretic at the last visit. And then you have his labs. So his fasting blood sugars in the morning are 130. Our goal is 80 to 130. Average 2-hour postprandial blood glucose is 234. We want it less than 180. Serum creatinine is normal, and his last A1C from before was 7.7%. So what do we want to do now? So thinking about this patient, they don't have good blood glucose control, and their A1C is not to goal. Their postprandial blood glucose are elevated. We have lots of options. We could do start empagliflozin 10 milligrams a day, which would be the appropriate starting dose. We could start saxagliptin 5 milligrams a day, which is one of our DPP-4 inhibitors. We could start insulin, so insulin detamir 10 units a day. We could stop metformin, or we could do nothing and bring him back in 4 weeks. So if we were managing his diabetes and we wanted to apply this information, what do you guys think you would want to do? Who wants to do A? I agree. So A, we have a patient with heart failure. They have good renal function, so they can take these medications, and they have uncontrolled diabetes, but their A1C is not terribly far off from goal, right? So 7.7%, these medications can work up to 1% A1C lowering, so it's a really nice option for this patient, I think. We wouldn't, saxagliptin's the one that saw the increased risk of heart failure. This patient has heart failure, we don't want that one. Insulin, their A1C, we haven't exhausted other options at this point. Insulin doesn't need to happen quite yet. We don't want to stop metformin, typically, unless we have to because of renal function, and then we prefer not to just do nothing. Okay, so then we have this patient, 59-year-old female with diabetes, coronary artery disease. She had a CABG back in May of 2017, hypertension, hyperlipidemia, and obesity. This is very similar to someone who came into clinic that had been admitted here, got their CABG, and then was coming to see me to help with diabetes management. A1C was 8.2. You see their blood sugars there. So again, postprandial blood glucose was definitely the worst of the two. Renal function was good. and their current medications are listed there. So they're on aspirin, they're on a statin, they're also on insulin, so a little bit different. This is Tresiba, insulin degludec, one of our newer basal insulins, and they're also on metformin at its maximum dose of 1,000 milligrams twice a day. What do you think you would want to do today? So we could increase her insulin, and again, this is a basal insulin, so if we think which blood sugars that typically helps, it usually helps with fasting blood glucose mostly. We could start liraglutide or Victoza, and you see kind of the titration schedule there. You could start mealtime insulin at 5 units with their largest meal of dinner. You could start a sulfonylurea, or you could do nothing and bring her back in 3 months and we'll check an A1C again. So who wants to do A, B? Yes. C and D? Yeah, I agree, B. So this is someone that could be an ideal candidate. So they're obese, they have heart disease, they have, their postprandial blood glucose is definitely the problem, and these medications work well for that because, again, they help your body give off more insulin when you eat food. And she needs pretty substantial A1C lowering, and these medications can do that. I'll say for this patient that actually came, so they were slightly different than this. Their renal function was a little bit worse, so we couldn't consider some other medications, like they couldn't be on metformin at the time. But what had happened is they got admitted, they were on Victoza, got admitted, had the cabbage, and then we put them on insulin because we're managing an inpatient. We don't have this medicine. But at discharge, we continued insulin and never restarted Victoza. A year later, we see them in the office and they're off Victoza, can't figure out why. It's just because we didn't resume it. And this could be a perfect person that we say, hey, this was a great medicine for you, even more so now that you have heart disease. Okay. And then my quick kind of wrap up with some caveats. So when we think about benefit for cardiovascular disease as a whole, you can see some listed there. You'll see that pioglitazone is listed on both sides because heart failure is still the risk. But we might see some other benefits. Semaglutide, there's a question mark only because we can't outright say it was superior, but we still take that data to believe that we are seeing similar benefits with that one as we saw with liraglutide. Okay, and that is what we were talking about with the GLP-1s. So what questions do you guys have either about this or anything we talked about last time?
In the